All right, I think we're in business. So EKGs. So we're doing all about EKGs. So you don't just have to recognize the rhythm and say, oh, that's sinus rhythm, or that's sinus tach, or that's AFib, or that's VTach. That's kind of what you learned in physiology as far as the P wave, the QRS, the T wave, and maybe what sinus rhythm, sinus brady, sinus tach looked like. But then now we're going to expand on that, learn a few more rhythms, but also going to understand what the causes of those rhythms are. Why do you have that sinus tach? Why do you have that sinus brady? Why are you AFib? What's the difference, right? So you have to know the causes of AFib, causes of VTach, causes of asystole, and then you have to learn the symptoms. The symptoms are the EKG strip itself, right? And sometimes there's a few symptoms that a patient might report, and if every fast heart rate they report palpitations. My heart, I feel palpitations, right? And then when they get serious, when they get complications of that rhythm, they're going to start getting more serious side effects, more serious symptoms, which we'll go into, right? And then you have to know the treatment for each one of these rhythms. How do I fix AFib? How do I fix sinus tachycardia? How do I fix this? What do I expect the fix to be, right? The doctor says give atropine for someone with sinus tachycardia. That is wrong. So you have to recognize that as a safe new nurse, okay? And finally, you have to know what the nursing interventions are. Luckily, the nursing interventions for every rhythm are pretty much the same, all right? There's very few things that are different, all right? And we test you on things that are different, so that's a good thing to recognize. When we say, oh, this is the only one that does this, that's probably a test question, right? Or this one's different, or this one's deadly, or this one's lethal, this one causes strokes, right? Only one of these rhythms causes a stroke, okay? All right, so EKG. Right, you may see when you Google questions, say in-class questions for EKG. ECG is also good, just K is just cardiac in German. Okay, so EKG basics. You're like, well, these aren't basics. This is all physiology and anatomy, and sometimes we have to refresh it. Some of us haven't taken anatomy and phys for 5 years, 10 years. Other of us have taken it 6 months ago, and you're like, this is boring. I already know this. Other people 6 months ago only intellectually vomited the material onto that physiology test, and they have forgotten it since. All right, so that's the idea behind understanding the anatomy and phys, and again, understanding this is where you get the why behind why is there an AV node block? Why do people have AV node blocks? Well, we have to know where the AV node is and what its purpose is. And SA node is like, why does the heart rate faster or slower? So that's the idea behind knowing the anatomy and phys behind it. Okay, so we're going to talk about the SA node up here, right? Up there in the what atrium is that? It's the right atrium, right? And the valves and atriums and ventricles, that will be valves. That will be cardiac on the second exam. But right now we're focused on the interior parts of those walls, the SA node, AV node, bundle branch. Here, AV nodes right here. There's our AV node, SA nodes there. Doesn't really show up that great. And then, of course, we have this big dividing line right here that separates the top half from the bottom half. What's the top half? Atria. What are the bottom half? Ventricles. Also, the top half is called supraventricular. When we talk about rhythms, we have ventricular rhythms down here, ventricular rhythms, and supraventricular rhythms up here. So we have tachycardias, which are fast or slow rhythms. Fast rhythms, they can have supraventricular tachycardias or ventricular tachycardias, right? And they have different, the cause is very similar, but the treatment will be different because our goal is to maybe work on the AV node when we're trying to fix SVTs, right? Maybe the atria are way too fast and you have a gatekeeper in the heart, and that gatekeeper is the AV node. So let's suppress the AV node so it doesn't let rhythms get through, so you slow down the heart rate when someone's heart rate's too fast, okay? All right, so we're going to the details of the different parts of the EKG. Okay, so there's always electrical activity, and then what precedes that, what follows that is a mechanical activity, right? So your atria depolarize, right? And then you can see that if you put some leads on the chest. Those leads are just like really low amplitude magnets, and they will deflect, they will go upwards when a positive force goes towards it. So when our atria depolarize, right, your EKG is going to see that. And that is called what wave of the EKG? That's the P wave, right? And we can look at P wave morphology. We're not really going to test you on that, look into that right now. But the P wave is, you can tell different things. You can tell someone has COPD based on their P wave. You can tell if someone has valvular issues based on their P wave. So you get a lot of information from the P wave, Okay. Just similarly, when you have after the P wave, that's the electrical activity. You have atrial contraction, which technically is systole is technically contraction, but when we say systole, we're really talking about the ventricles. So the ventricles are really the business maker of the heart. 80% of your cardiac output comes from the ventricles, right? That little 20% is that little atrial kick right at the very, very end of diastole. We kick that blood into the ventricles, and then our ventricles contract. And how did our ventricles contract? We had to depolarize them. We had to send electrical activity through the heart to depolarize those ventricles, right? So we depolarized it, and then ventricles are much more muscular than the atria, so you're going to have much higher amplitude electrical activity as you'll be able to pick up on that little tiny little magnet or lead on the chest, right? So that little wave that comes for ventricular depolarization is called what? The QRS, right? So our atrial depolarization is there, and then we got ventricular depolarization, and we can recognize that on the EKG. And the ventricles are sick, they're delayed for some fashion. That QRS can get longer and longer, it can get bigger, right? The other reason why that QRS might be big or I should say, well, the reason why it's thin is because we have highways through the ventricles, right? We have a little highway that goes straight down from the AV node to the right and left ventricle. It's like your 405 and 5. Anybody know LA traffic? Yes, all right, so you got the 405 and 5, you have the 405 going to the right ventricle, and the 5 going to the left ventricle, right? And those are your freeways that go through the heart, right? But for instance, if you have a blockage on the 5 or the 405, right, now you have to go through all the little side streets all the way across to depolarize all the ventricles, because as we'll learn, all the cells depolarize cell to cell to cell to cell, all right? So that depolarization can be longer if we have some blockage in the ventricle, all right? Or if the impulse came from the ventricles. So we have PVCs. What's a PVC stand for? A premature ventricular contraction. So that means we had an impulse that came all of a sudden came from the right ventricle. Bam, PVC. Maybe we tickled it with a central line insertion. We're putting a central line into their neck. It goes all the way down to their right ventricle, and we tickled the ventricle, right? And that caused them to have a little PVC. All right, so the PVC generated from the right ventricle, generated from the 405, maybe Santa Monica Boulevard right there, and then it has to go all the way across Ventura, all the way over Hollywood Boulevard, and it's going to make it all the way finally over to, what's over there? Eagle Rock, maybe? I don't know. So it has to go all the way over to the east side of LA. And it's going to take a second to get all the way across. So our QRS can be prolonged in those situations. Okay? And then our ventricles have to be, and our atria for that matter, have to be set up for the next cycle, right? So they have to be, you turn the light switch on, they're depolarized, and then you turn the light switch off. So they can be turned on again, right? The light switch can't be turned on until it's turned off. So our atria will depolarize, the light switch is turned on, and they have to repolarize. And they actually repolarize right in the same time as the ventricles are depolarizing. It's happening at the same time. But the ventricles, we can actually see the repolarization out here on the T wave, right? So the light switch is being turned off, so the ventricles can now be depolarized again, right? So that area between when the light switch is on at all times is the refractory period, meaning that you can't submit any other activity. But there's a little vulnerable piece right over here, right? As soon as the light switch is like halfway, I don't know if you've seen a light switch spark before, we turn it off and on, off and on, off and on, and you see a little spark at the end. That's kind of that little period right there, right before when our light switch is coming off. It's vulnerable to create an electrical spark, and electrical spark can lead to VTAC, right? And VTAC is deadly. So that's a vulnerable part of this whole cardiac cycle, or this whole electrical depolarization, repolarization situation, okay? So yeah, so we have different intervals in the bottom right corner there. So those intervals, we talked about the P wave, we talked about the QRS complex. Technically there are different parts of the QRS. When you're looking at the nomenclature, we're not going to test you on the different nomenclature, whether the S wave or Q wave is the first or second negative deflection after the isoelectric line. No, we're not going to test you on that. There's bigger fish to fry, which are what's the causes, what's the treatments for these different rhythms. But this will get you to understand why I have a AV node block. When I have an AV block, I'm going to have a prolonged PR interval. And what's the PR interval? It's the measure between the P wave and R waves of some fashion, but it's always it's from right here to right here, right? So there's a PR interval, and we'll zoom in more on the PR interval. We actually have a slide dedicated to the PR interval. But that's the time it takes from atrial depolarization to the time it hits the, what's this little piece right here? The AV node, right? Or until it technically allows the impulse to go through the AV node. Because once it goes to the AV node, we get a what? Once it's going down these little freeways right here, you get a QRS complex, right? So it's going to start changing directions, going negative and positive. You're going to get a QRS. So that PR interval measures the time it takes from atrial depolarization to the time we let an impulse get through the AV node. And if we're on a medication that suppresses the AV node, right, it's going to take longer, right? If we're taking a beta blocker, some calcium blockers, digoxin, et cetera, these drugs will delay the time it takes to get that, for that impulse to make its way from the atria to the ventricles, right? And the reason is because it's blocking that AV node. Okay, so there's PR interval, and the other important interval, ST segment you'll deal more with in MedSurg 3, so you're only MedSurg 1 right now, right? The other thing is the T wave. Sorry, I don't have a ladder to fix the projector to make it go up a little bit more, but nor can I bring the screen down further. So down there we've got the T wave, all right, and that's just your ventricular repolarization. Also, another important interval is the QT interval, QTC technically, and we'll talk about that. Okay, and we'll talk about why that's important. Okay, so again, the PR interval, there's a little delay at the AV node, and that will, if you have more and more delay, you can even block the impulse to going through at all. That's an AV node block. The worst kind of AV node block is nothing gets through, right? All you have is P waves, and the QRS is going to do its own thing eventually, because our cells have what's called automaticity. So what does automaticity mean? It sounds like automatic, right? So the cells depolarize automatically if they don't receive an impulse in time. If you don't receive the go, or like if you're like in a relay race, you're like, well, shoot, no one, they didn't come. Now you're going to go ahead and finish your leg of the race, okay? Because your body's depending on you to eject that blood and form a cardiac output. All right. Any questions on the electrical activity preceding mechanical activity? So this is just linking up to when we talk about the cardiac section for exam 2. This was what you needed to have a good cardiac output. Okay, so different pathways. So again, the SA node fires off. The SA node is where it all starts, right? Our SA node is right up here, right there as well. Our SA node fires off automatically, and at what rate? At 60 to 100 beats. So if someone's heart rate is 60 to 100 beats, what's the SA node stand for? Sinoatrial. So it's atrial because it's the atria, but sino sounds like sinus. That's why it's called sinus rhythm or sinus tachycardia or sinus brady. Well, normal physiological heart rate is sinus, right? Sinus rhythm. So that starts right here in the sinoatrial node, the SA node, and it fires off at 60 to 100 beats per minute. If it's more than 100, it's sinus tachycardia. It's a fast heart rate. If it's sinus bradycardia, it's less than 60. Okay, but we do have other options in case our SA node fails. If the SA node fails, then the AV node takes over. The AV node fails, then the Purkinje fibers take over, or the junction technically, and then the Purkinje fibers then go all the way down, all the way to the bottom, you create a little ventricular rhythm at 10 to 20 beats per minute or 20 to 40 beats per minute. That's really next semester we'll talk about the really, really slow rhythms and pacemakers and such. Right now we just want to focus on SA nodes, AV node blocks, atrial rhythms, and ventricular rhythms. Okay, so normally SA node fires off and then it goes cell to cell to cell, all right? So it goes cell to cell to cell to cell, and then it hits the AV node, right? And the AV node allows the impulse to go through. Okay, there's a physiological delay, and that delay is allowed so that you can actually dump the blood from the atria to the ventricles. If it wasn't there, you wouldn't have a time to fill the ventricles to last little 20%, last little atrial kick. Okay, so again, when one fails, the next one will take over. It goes SA node to AV node to bundle to the junction to the ventricular. So all those things is their backup system in case your SA node were to go offline. All right, but normally when we talk about the SA node, it can get faster or slower. We can raise the SA node rate or lower the SA node rate. All right, because if we're exercising, for instance, we want to have more blood circulating around. So how do you get more blood circulating around? You don't just say SA node, do your thing, right? It has to be, it's an intrinsic thing that your body does, right? So we raise and lower our heart rate with the parasympathetic and sympathetic nervous system. So the SNS is going to be talked about many, many times. We're going to say SNS, 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 because it has a lot to do with cardiac, a lot to do with respiratory, a lot to do with renal, a lot to do with a lot of things, right? So you really have to know your SNS, and you have to know those receptors that are attached to it, right? So we talk about the SNS that they attach to they will innervate the heart, and they come from the brain, right? Comes from the brain, goes to the heart over here. This is actually the output right there. All right, you got a little sympathetic nerve, goes to the heart and says what? Is it going to speed up or is it going to slow down the heart? What does the SNS do? It's going to increase the heart rate, right? SNS is your fight or flight response, right? When you're scared, when you're anxious, when you are drinking caffeine, when you are exercising, when you're pushing a bear off your outside fence, those things are going to raise your heart rate, right? And your body will do that. And how does it know to do that? How does it know that I need to raise my heart rate? Well, just like anything, if you have a little Nest doorbell or you have a little, what's it called, just a camera on your door, you're going to know that, oh, there's something there. I need to hide because I don't answer my doorbell in 2024, or I need to, open the door. I need to do something about that stimulus that's there, right? So your body has all kinds of inputs. So some of those inputs might be just movement of the leg. If I move my leg enough, my heart rate will go up, right? You have little mechanoreceptors in your knees and your arms and such. Other things that are important here are blood pressure, for instance. My blood pressure is low. How do I fix that? How's my body going to fix if my blood pressure is low? Well, we have little baroreceptors in the aorta. It's always checking the barometer or the pressure in the aorta. If that pressure starts getting low, what's your body going to do about it? So, I guess the pressure is low. I can't do anything about that. No, it has a direct route to the brain. And it says, hey, the blood pressure's low out here, guys. What are you going to do about it? It's like, I know what to do. I'm going to raise the heart rate. How is raising the heart rate going to fix your blood pressure? Well, your heart pumps blood, right? And if I pump blood more per minute, that's called what? That's cardiac output, right? So that cardiac output comes out. If I increase my cardiac output, that will increase my blood pressure. Blood pressure is just the pressure against the aorta, right? Against the arterial walls. So same thing if there's not only BP receptors out there, there's O2 receptors out there, little O2 receptors out there. So the O2 is low in my aortic arch, in my carotid bodies, then it's probably low in my brain. It's probably low in my liver. It's probably low in my big toe. So how do I increase O2 delivery? Well, we're going to increase the heart rate. So that's going to increase blood flow. What does blood have in it? Oxygen, right? So same thing, there's CO2 chemoreceptors. We have a slide dedicated to SNS as well. We have all these different receptors out there that will feed into the brain and tell it, one way you could fix this is raising the heart rate, right? So if I raise the heart rate, that should fix a low O2. That should fix someone that's exercising. That should fix someone that has a high CO2 or a low pH. That should fix someone that has a low blood sugar, all right? Or someone that's anxious might fix that, I guess, right? So all these things are inputs, and then our brain will output via the SNS, right? SNS fibers, and they will go to the heart, and they will attach to the heart, and they attach to the heart specifically on specific SNS receptors. And those receptors are adrenergic receptors, or receptors for adrenaline, right? Adrenaline is what gets your heart racing. So that adrenaline, and that is that's an accelerator, right? So you hit the accelerator, that's going to raise your heart rate, and that accelerator on the heart is called a beta-1 receptor, right? You have one heart and two lungs, so beta-1 receptors are on the heart, beta-2 receptors are on the lungs. When we talk about lungs, and for exam 2, or I think exam 3 actually, we'll talk about beta-2 agonists that open up the lungs, and raise the respiratory rate, which is good. If O2 is low, we want to bring in more oxygen. So that's when we talk about lungs. But for the heart rate is concerned, we're going to raise the heart rate when it attaches to a beta-1 receptor. So if we have a beta-1 blocker, a medication, a beta blocker, it's going to block beta-1 receptors. It's going to block other stuff too sometimes. It might block beta-2, might block alpha-1s. But when it blocks the beta-1 receptors in the heart, what's going to happen to our heart rate? Increase or decrease? Decrease, because the whole purpose of the accelerator is like where you're never supposed to have like a ball or bottle next to you flying around in the car. All right, that bottle gets underneath your accelerator. You're not going to be able to go fast because on your brake, that's more of a problem, I think. But you're going to not be able to go fast. Therefore, you're going to slow down, right? So beta blockers, for instance, are going to block the beta-1 receptors in the heart, therefore causing a higher heart rate. a low heart rate, right? That's what beta blockers do. If you have a beta agonist, like when we talk about respiratory, we give beta agonists to them to open up their lungs, but also goes to the heart and causes a side effect of increased heart rate, right? So that's because it's attached to beta 1 receptors. Sometimes people have really, really low heart rates. We can give beta 1 agonists in the form of epinephrine, right? Epinephrine is your body's normal juice, your normal adrenaline juice, right? Epinephrine and norepinephrine get released from where? Where at? I heard ovaries, not ovaries. Where at? Adrenal, the adrenaline glands, yes, the adrenal glands, adrenaline glands. Where do the adrenaline glands sit? On top of your kidneys, little sombreros, all right? They got their cap backwards, they got the sticker still intact, rim not bent. Anyways, they have all those things. That's the adrenal glands are on top of the kidneys, and they secrete norepinephrine and epinephrine. That's your body's natural SNS juice, right? It maintains the SNS nerve activity, okay? Also, you release norepinephrine right down here. You're actually releasing norepi through those little nerve terminals onto the beta 1 receptor. But your adrenal glands will release that juice, and it will circulate through your whole body, and it will do, yes, it will raise your heart rate, and it has other effects as well, okay? So that's the SNS, right? We have beta 1 receptors, all right, via sympathetic fibers that will increase heart rate, but it's also going to increase contractility. So not only does your heart rate go up to raise your blood pressure or to output more blood per minute, but also you're going to increase contractility. You're going to contract harder, right? The muscles will actually contract not only faster, but harder, right? And it will squeeze more blood out, right? So if you know your physiology, you have end-diastolic volume and end-systolic volume, you're going to reduce that and you're going to get more stroke volume, okay? So meds promoting beta 1 activity, epinephrine, norepinephrine, okay? Dopamine is just a precursor to, it's the building block of epinephrine and norepinephrine. These are medications we can start on patients in the hospital. We can give someone an epinephrine IV push. We can give norepinephrine via a drip in the ICU, same thing with dopamine in the ICU. And you'll talk more about these drips and moving them up and down to fix someone's heart rate or blood pressure in MedSurg 3. But we'll talk about epinephrine, for instance, is one of the treatments for someone that has a low or high heart rate, do you think? A low heart rate. If someone has a low heart rate, you can give epinephrine. You can give a dopamine infusion if someone has a low heart rate as well. Okay. The medication we give a lot, though, is atropine. So atropine is a medication we give for someone that has a low heart rate to fix it, right? But atropine does not work on the beta 1 receptors. It kind of goes, it takes an extra step, right? It's an anticholinergic, so it blocks choline, right? What is choline? It's acetylcholine. And where's acetylcholine in this whole picture? Acetylcholine is released by parasympathetic fibers. So your parasympathetic nervous system is the brake to your SNS, right? You have the PNS, but you have to say slowly, otherwise it sounds like you're saying penis, right? So PNS is the opposite of your SNS. So the SNS is the accelerator, the PNS is your brake, right? It's going to brake the car or the heart, right? It doesn't do that via SNS fibers, otherwise that would be SNS, right? It does it through parasympathetic fibers or PNS fibers. They go down via the vagus nerve, right? So the vagus nerve has many, many other activities, but it's going to also innervate the heart, and it's going to release acetylcholine down here. It's getting a little busy. I think I talk about this more on another slide. But acetylcholine gets released from your vagus nerve, and that will then attach to your heart, and it will tell your heart to brake, right? And how does it tell it to brake? We'll talk about that, but it's going to ultimately decrease the heart rate and decrease contractility. It's going to pretty much stop the SNS activity and also lower the heart rate, okay? So acetylcholine is the bread and butter for the parasympathetic nervous system. If you have acetylcholine or you have a parasympathomimetic, what does that mean? Parasympathomimetic, mimetic meaning mimics. It's the same as parasympathetic stuff, right? So there's some of the drugs we talked about, like in neuro coming up. It's for exam 3 actually, but it's like stop talking about other future exam stuff. All right, so but exam 3 has, we talk about neuro. We have parasympathomimetics, drugs that will mimic the parasympathetic nervous system, and they will bind to acetylcholine receptors. And one of your side effects of those meds are bradycardia, right? Because that's what happens. That's how it works normally. So if I give a medication that's going to promote that, I'm going to get more of that activity, right? So acetylcholine binds to the heart on parasympathetic receptors, and it will release acetylcholine, and it will lower the heart rate, right? So meds promoting acetylcholine activity, cholinergics or parasympathetic mimetics, if you want to impress your friends and relatives. But beta blockers, why do they promote acetylcholine activity? I thought, what? How does that work? Well, if I have a beta blocker and I'm blocking SNS activity and blocking norepi, I'm going to have more acetylcholine activity, right? I'm going to have more parasympathetic activity. All right, so beta blockers lower heart rate, cholinergics will lower heart rate, and digoxin is going to lower heart rate because digoxin actually promotes vagus nerve activity. So vagus nerve is my parasympathetic nerve, and that's going to lower the heart rate, right? Also, your vagus nerve, it goes to your gut and makes you nauseous. So, and it can make you vomit as well when you have more vagus activity. So that's why you can, with digoxin, you have nausea, vomiting as a toxicity of digoxin. So when it has too much digoxin on board, they can be vomiting all the time. Okay, and their heart rate's gonna be low too. Okay, so these meds don't specifically work on acetylcholine receptors, but they will lower the heart rate, such as calcium channel blockers, adenosine, and amiodarone. And we'll talk about our different meds. So this is kind of the precursor to understanding our medications and how they work. And that's why meds are so scary, is because you have to apply your physiology. You have to apply how the meds work, what the meds are doing. They're either blocking something normal or they're promoting something normal. Okay? And your side effects are going to just fall into place. It's very rare that you can get some kind of weird side effect. It usually all kinds of falls in. The puzzle usually always falls in, and I'll point out when something is rare or you just have to know it, right? But that's few and far between. Usually you can figure out how a disease works or why a disease has side effects or symptom X, or why a medication has symptom Y, right? And why you should teach them side effect Z, right? So for instance, like beta blockers, beta blockers, they're going to block the beta 1 receptors, and they actually block beta 2 receptors on the lungs, and that's not good for someone who's asthmatic or COPD. That's not good because that's going to not let them bronchodilate, which is one of our SNS activities, right? So yes, it will help someone's fast heart rate, right? Give a beta blocker for a fast heart rate, it lowers the heart rate. But if they have asthma or COPD, that's going to be not good when they have a COPD attack or an asthma attack. Okay. All right, any questions on this overview of parasympathetic sympathetic? All right, so you can change the heart rate with the parasympathetic or sympathetic, which we just talked about, right? But there's other things. So these are causes of an elevated heart rate or causes of a low heart rate. That's what we're getting at here. So when we talk about sinus rhythms later, you talk about sinus tach, it's like, oh shoot, I know sinus tach. That's when they might be taking atropine, or they might have epinephrine on board. They had a allergic attack and they took an EpiPen and they raised their heart rate. Why is the heart rate so fast? Well, because they had an EpiPen. Epi binds to beta 1 receptors, raises the heart rate, right? It's mimicking the SNS. So SNS and PNS, that's your gas and brake, right? And then we have electrolytes. So electrolytes can either raise the heart rate or lower the heart rate, right? So potassium has the most effect of all of our electrolytes. So if we're talking electrolytes and or you say potassium, a knee-jerk reaction should say heart rate, right? So because potassium affects the heart, but they might cause restless leg syndrome. That's not really our primary concern. When someone's potassium is high or low, it's always heart rate. A question's not going to ask you, oh, they might have some constipation. No, it's just going to ask you, like, my first priority is to look at the heart rate, right? You can feel for an apical pulse, maybe it might be slow, but usually when we talk about potassium, it's going to change your heart rate up or down. Okay, and really, when it's really, really high, potassium is going to actually cause a low heart rate. When potassium is low, it's actually make your heart excitatory, meaning that it's any kind of irritation is going to make it have ectopic activity. What's an ectopic activity? What does that mean? Ectopic activity is like a PVC or a PAC, a premature ventricular contraction or premature atrial contraction. Anything can make it's like on edge, I guess is a good way to see it. It's very, very on edge when your potassium is low. So anything can make it just go into a spout of paroxysmal SVT, or anything can make it just go right into AFib real quick, right? It doesn't necessarily directly cause tachycardia, but it makes you very high risk for a little tachyarrhythmic event, okay? So potassium is really, when you talk about electrolytes, potassium equals cardiac, right? So cardiac is potassium. And then calcium is like second place, like a distant second. So like if first through fifth place are potassium. And then once you get to sixth place, now you're talking about calcium. Calcium will affect the heart as well. And calcium has other effects when it's high or low, but like it has like Chvostek's sign, right? Was that high or low calcium? You did fluids electrolytes, right? Last semester, right? It's Chvostek's sign and Trousseau's, that was low or high calcium. That was low calcium. That makes you, it's just the same thing as low potassium. Makes your heart irritable, makes your heart very, very close to threshold to cause it to go off, right? It's very, very on edge. So when your calcium is low, and the same thing when your potassium is low, it makes your heart very, very on edge. Not necessarily making you tachycardic, but you could very well be tachycardic or have a little episode of tachycardia for like 3 seconds or so. Okay, so Chvostek is where you tap the cheek and it causes their nerves to twitch. Kind of same thing on the heart, it causes it to twitch, right? And when your calcium is super high, it's kind of the same thing as when the potassium is really high. It's going to cause your heart to be suppressed, and it's going to cause bradycardia. Okay, and then magnesium. Same story. It's kind of the same. Nice thing is that all three of the electrolytes have the same kind of symptomology when it talks about the heart. When all three of these electrolytes are high, you have bradycardia. When all three of the electrolytes are low, you're at risk for tachycardia, and you're at risk for ectopy and PVCs, PACs, and actually you're at risk for a lethal rhythm. Who knows the lethal rhythm that you're at risk for when all the three electrolytes are low? SVT? Not SVT. You can have little episodes of SVT, but more, I think I heard it. BFib, no, torsades, all right? So torsades is, we'll talk about, that's polymorphic ventricular tachycardia. We'll talk about torsades, and that's a deadly rhythm that you want to avoid. So that's why we've replaced these electrolytes. We replace potassium, replace calcium, we replace magnesium so that we can have a good heart function. And also you might have some other side effects, but those are that's the primary reason you're giving these medications, to fix that, right? And if you have the choice to give magnesium or give potassium, which one do you give first? Magnesium. Why? Because why? So how do you remember that in clinical? Because I'm going to ask you in clinical, and someone's like, I don't know, and they're just going to do 50-50. You're going to pull a coin out of your pocket and say, oh, it might be potassium, but that's not the right answer because it's magnesium. Why is it magnesium? How are you going to know that for forever? So magnesium is what? It's a key, right? So it's a key down there in the bottom right. It's a key for all the protein channels and enzymes pretty much throughout most of the body, right? It's a major key, major ingredient for enzymes and protein channels to work. And what protein channels are we concerned about right now? You could say the heart, but really we're more concerned about, what's that? No, you're thinking, no. Magnesium and calcium, yes, they have a relationship, but that's not it. You need magnesium for potassium. Why? What's the connection there? I heard it. Yeah, you got a pump. Where do you have little sodium potassium pumps? You have them in the heart, you have them on nerves, but you also have them in the little divas south of the diaphragm. What are they called? Kidneys. You said lungs? No, kidneys. Kidneys are south of the diaphragm, right? They have their whole job in life is to take nutrients from the urine and put it back in the bloodstream or get rid of stuff, right? That's their whole job. So if you want to hold on to potassium, right? And how's your body hold on to potassium? In the presence of actually less aldosterone. But anyways, if you want to hold on to potassium, all right, your kidneys will have to slurp it up. And how do your kidneys slurp it up? They have little protein channels that will take the potassium and put it back into the bloodstream, right? And magnesium is there to do it. So if someone's potassium's low, it's like, well, I'm going to give them potassium. And it's like, well, what's the magnesium level? It's super low. I don't know if I should replace that or not. Well, you need magnesium to absorb the potassium, right? So, and that also works in the gut too, but the kidneys are really, they're getting so much flow per minute, right? And they're really the ones that are going to adjust your potassium level, okay? So electrolytes can either raise or lower your heart rate. And then we have meds, okay? So we kind of touched on some of these meds. These meds might interact with the SNS or PNS in some fashion, right? So some pathomimetics, or you might see in reading, you might see adrenergics, you might see catecholamines. They have like 5 different names that just mimics the SNS. I think they're in the witness protection program. I'm not sure why they have so many different names, right? But epi, norepi, dopamine that we talked about in the previous slide, all those guys are going to mimic the SNS, and therefore you have a high or low heart rate. You have a high heart rate, right? And you have SA, AV node blockading agents. So they block the SA node, or they block the AV node. You have a drug that you give that will block it. Well, if you block the SA node, it can't respond to beta 1 receptors. It can't respond to stuff, so therefore it's going to cause a low or high heart rate. A low heart rate. So beta blockers are the examples of medications, and then non-DHP calcium blockers, and we'll talk about what that means. And digoxin is going to be a medication that blocks the SA node and AV node for when someone has a high heart rate. We want to block it and therefore lower their heart rate because their heart rate's too fast, right? And we got hyperpolarizing agents. So I'm going to tell you what hyperpolarizing is. Is like, well, just tell me that it lowers the heart rate and get on with it. Well, this is how you can get to the right answer every time, so that you understand, kind of apply your physiology and apply those things, right? That's the idea we're talking about here. Okay, so you have medications that hyperpolarize. What does it mean to hyperpolarize? We mentioned the word depolarize a few slides ago. What does hyperpolarize mean? It's the opposite direction, right? So for your cells to go off, right? Your cells just don't go off just because. The light switch doesn't just go on just because. You need a finger underneath the light switch to raise it up, and that finger is a stimulus, right? For that light switch to turn on, for us to depolarize spontaneously, for our SA node to spontaneously go off at 60 to 100 beats per minute, it needs to depolarize, right? It needs to has a tiny little stimulus right here, a little stimulus that reaches threshold, and once it reaches threshold, it will depolarize, right? But what if we make it harder? What if we hyperpolarize it? Make it harder to reach threshold. Well, if you're looking at that many complexes per minute, it's going to be less because it's going to take longer for it to reach it. Just like if you live across the street versus if you live in Palmdale, it's going to take you longer to get here. If you have to come here 100 times per minute or 60 times per minute, right? It's going to take you longer to get back and forth, right? And then once we have this little depolarization here in the SA node, that's going to be the stimulus actually for the next cell right next to it, right? So here's our SA node blown up. So there's SA node, just blow that up, and that SA node fires off at 60 to 100 times per minute, right? And when it fires off, it creates a positive depolarization next to it, and it's going to depolarize this cell, and that cell is going to depolarize the next cell. That stimulus is going to spread through the whole heart until it hits what? The AV node. The AV node is going to stop everything. So hold on, guys, I got to gather my thoughts, and we're going to let you through. And then when it lets it through, you get what? Ventricular depolarization, which is what waveform on the EKG? That's your QRS complex, right? So you get a P wave, which is atrial activity, then you get QRS complex, which is your ventricles depolarizing. So we can have medications that will hyperpolarize it. And adenosine is going to actually turn everything off, right? Just like when anything doesn't work in real life, you just turn it off and on again, right? It's the same thing with adenosine. It's like, hey, my heart's not working, it's too fast. Well, let's turn it off and on again, see if it helps, okay? So that's what they do. You just fire off, you open up all the potassium channels throughout the whole body, including the heart, and it just hyperpolarizes to nobody's business. And then the medication only lasts 8 seconds, right? Adenosine. So you can't discharge someone on adenosine. That is, every 8 seconds you got to take this medication, okay? Otherwise your heart will be super fast. So that doesn't work. But adenosine is given in the hospital setting. You give it, and it's going to hyperpolarize the heart all the way down to nothing. Literally, the heart stops. They are dead for like 3 to 6 seconds, sometimes longer. That's why you have the crash cart nearby in case they don't come back, right? So you just restart the heart. You turn it off and on again, and we'll have a video of what that looks like. It goes all the way off, and it boots back up. The Windows sound. I can't do a Windows sound, but it just boots right back up, all right? So a hyperpolarizing agent is going to, lower the heart rate, okay? Amiodarone works a little bit like that too, and we'll talk about how that works. Okay? Yes?
So hyperpolarization, does that make the QRS complex get bigger at all, or it just goes away completely?
It's going to slow down the SA node. That's really what's going on.
Okay.
And it's going to slow down conduction through the heart too. So it's going to take longer for things to get through. Okay, when we talk about amiodarone, it actually prolongs a few intervals, and we'll explain how that works. Okay? And then you can have structural damage. So if you have a scar tissue, let's say we have scar tissue right there, That's going to take longer for this impulse to make its way all the way over there. We have a scar tissue right here. It's going to take longer. It's going to depolarize quickly that way, but it's going to take longer to get all the way across to depolarize that whole heart, right? So you can have structural damage that might cause a prolonged intervals, but also might cause arrhythmias like AFib. The only reason why someone has AFib, like a fast AFib versus a fast sinus tachycardia, is because they have scar tissue, right? It could be scar tissue or it could be like dilated tissue. So we have like a huge dilated atria right there, right? Because they might have a valve disease, they might have hypertension, they might have something going on that's making their atria big. Well, now normally the heart's expecting the impulse to go from point A to point B right there, but then this guy's like, wait for me, I'm still depolarizing, and now you have an ectopic site. So it might display as a flutter, but it might be AFib, which is an unorganized atrial activity, right? And you don't see P waves, you see all kinds of different centers that are going off. Okay, so you have an MI, which can cause scar tissue. What's MI stand for? Myocardial infarction or heart attack, all right? And then once they recover from that, if they recover from that, then they get they can develop scar tissue. If they didn't seek out medical help within 1 hour, they didn't get a door to balloon time. If you've ever seen in the ER, it's like it's a priority to get a patient that has an MI into the cath lab to fix their heart, right? But maybe they didn't. Maybe they live in Ridgecrest, right? And they took a 2-hour drive down to the hospitals up here, and then they had problems, right? They could develop scar tissue because of that. And that scar tissue is going to cause abnormal EKG stuff, but also puts you at risk for AFib, puts you at risk for PSVT, puts you at risk for VTAC, VFib, all these different things we talk about are all these different abnormal rhythms we talk about that are not sinus are a result of MI, CHF, valve disease. All these things are causing either scar tissue or ballooning out of the ventricles or ballooning out of the atria, making us at risk for these things. So if you're creating a table on causes of arrhythmias, for sinus rhythms, sinus brady, sinus tachycardia, that's the stuff up top. The ANS, which is the autonomic nervous system, right? Making a higher load, might be on medications. A medication is not really going to put you into AFib, right? That's not what medications do. They're just going to block normal physiology. But if someone has abnormal physical structures in their heart, that's one of the causes for like VTAC, for instance. It's one of the causes for SVT, one of the causes for a flutter. All the rhythms we have to know for the test. Okay. All right, so you can dilate a ventricle, you can dilate an atrium, or you can make it hypertrophied, which means it has more muscle compared to the rest. So this one is hypertrophied. And that can cause problems in our electrical conduction, right? Same thing if we are dilated. That can cause problems in the conduction through the heart, and therefore we can have problem rhythms, right? All right, and then genetics can be an issue. That can cause dilation, hypertrophy. That can cause abnormal conduction pathways and such, which we're not going to get into, like Wolff-Parkinson-White. We're not talking about that. That's an abnormal, rare thing that we see like 3 times a year maybe in all the patients that come to the hospitals. Okay, but yes, in Wolff-Parkinson-White, they have an abnormal conduction pathway that allows the impulse to get through on the side and cause a really fast heart rate because of it. Okay, so changes in all these things will cause electrolyte channels to open or close, right? And when you talk about these little channels in the heart, right, these channels will either make the heart cooler or warmer. And what that means is it will make it depolarized or hyperpolarized. Hyperpolarized being cooler, it's getting colder and colder and colder. It takes more impulse, more stimulus, make it reach thresholds, right? So we can make it cooler or warmer, and electrolytes do that. We have little electrolyte channels, right, that will open up or close. And some of them are on an automatic circuit, right? Those are the ones that are above threshold. They will all open up, or they will all close, and they will allow that's what creates the impulse. We want the impulse to go up, get really, really warm, really, really hot. You want the impulse to get really, really cold so that you can, turn that impulse on again in the future. Okay? So we have a pacemaker potential right here, and that's automatically firing off at all times, right? And we have a cardiac action potential, which is all your muscle fibers. That's what they look like. And they have the little plateau phase, which is for calcium, because you need calcium to do what? To bind to your tropomyosin, displace the actin, to make it so that you contract the Z line. Who remembers that? Right? So it's going to do all that stuff to contract. You need calcium to contract your heart, right? And that calcium is stored away, actually, and it's ready to go, and it's going to then release and then cause the heart to contract, okay, when it receives that impulse, okay. So we have pacemaker potentials that will affect the heart rate, right? So if our pacemaker, which is our SA node, right, if that is going faster because of medications, for instance, or meth, right, or cocaine, that's also going to, that's a sympathomimetic. That's going to, when you have to intake a little bit of meth, a little bump of cocaine, that's going to cause the heart rate to go up, right? And that's going to cause the pacemaker potential to be more and more depolarized, okay? And the cardiac action potential, all right, that's going to be the cardiac muscles right here. Those guys are going to, can increase in their contractility and allow more output of blood if it is SNS activity, or less if it's parasympathetic activity. So all these channels are moving, and they're causing a opening up of channels or a closing of channels. And then we have medications that will open up more channels or close more channels, right? So potassium, you want to consider as cold water. That's why it's blue there. So when you open up more potassium channels, you're going to get cooler. You're going to normally bring the cardiac action potential down, right? So it normally brings the cardiac action potential down. So all the potassium channels close at the beginning right there, and all the sodium channels open. So that makes hot water rush in, because sodium is hot, if you want to think of it as hot water, and it's going to come in and make it go all the way up. And then calcium will come across, but then also we have, then all the sodium channels close and all the potassium channels open, and then we come back down to baseline. So you can see the potassium channels are open at rest, they all close, the sodium comes in, calcium comes in. There's some potassium channels that are open, but then all the potassium channels open, and we are now back to our baseline, right? So that's kind of how it all works. The reason why I tell you how it works is because when we gave like amiodarone, for instance, amiodarone is a K-channel blocker, right? So it blocks potassium channels. So if I block potassium channels, sorry, I'm saying that right. If I block potassium channels, it's going to prolong the rhythm there, the EKG impulse, right? The cardiac action potential. Okay, so that's our overview of what controls the heart rate. Okay, so we talked about the ANS activity, kind of talked about this already, but you know, we affect those pacers, the SA node, AV node. Okay, there are systemic symptoms that will result, and the reason why I tell you about systemic symptoms is because the SNS not only affects the heart, it affects the blood pressure, it affects the pupils, it affects the sweating, it affects the my blood sugar. All these things we'll talk about in other disease processes. So it's important to understand it now, because it's going to be coming back almost every disease process. Every disease process is going to be manipulating the SNS in some fashion. For the most part, about 90% of diseases will alter the SNS, right? Like we talk about diabetes, and someone gets hypoglycemic, well shoot, low blood sugar is going to tell the brain say, hey, the sugar's low out there. And yes, it will raise your heart rate and raise your blood pressure, but it's also going to go to the liver and tell the liver to make more sugar, right? So it's a input, low blood sugar is a stimulus for the SNS, and the SNS will fire off. So when someone's hypoglycemic, they have tachycardia, tachypnea. They have diaphoresis as well. They might salivate, I guess, but where's my diaphoresis at? It's on there somewhere, right? So those are all things that will happen when I have low blood sugar. So you just copy and paste it. Once you learn the SNS symptoms once, that's pretty much for every disease process, unless that disease process is altering one of those symptoms, right? So when I'm hyperglycemic, why do I have SNS symptoms? Well, because low blood sugar stimulates the SNS. Why does high blood sugar cause SNS symptoms? So when I'm hyperglycemic, we'll come to learn that it makes you dehydrated. When you're dehydrated, you have a low blood pressure. So someone with hyperglycemia has tachypnea, tachycardia, right? They have pupils that are dilated. They're not going to be sweaty because they're dehydrated. So that's the little alteration I was talking about, right? So all those things are a stimulus for the SNS, and that's going to cause the symptoms. So instead of rattling off symptoms for disease processes, you could say, just copy and paste, oh, it stimulates the SNS, right? So that's going to be the same symptom. When someone's hypoxic, and we talk about respiratory diseases, and someone has hypoxia, well, low O2 stimulates the brain to fire off the SNS, and when someone is hypoxic, heart rate's up, right? Someone's hypoxic, they're breathing fast, because not only does the sympathetic nervous system go to the heart and increase your heart rate, but it also goes to your lungs and will increase your respiratory rate and increase the amount of air you're breathing in, bronchodilate as well. So that makes sense, right? If our O2 is low, how do we make our O2 higher? We're going to breathe more. Okay. So what happens when you have an SNS response? It's due to these things, and we'll talk about pH and CO2 not so much next week, because next week we have a holiday, but when we talk about ABGs, we talk about O2, CO2, and pH, right? And when pH is low, when bicarb is low, when CO2 is high, we talk about all these things, that stimulates the SNS. So we talk about ABG symptoms. If someone has metabolic acidosis, guess what? They got tachycardia tachypnea. All right, how do you memorize that? I got tachycardia tachypnea, diaphoresis. Oh shoot, he never tested me on pupil dilation, but pupil dilation is also a result of the SNS, right? Those are all an effect of someone that has an SNS stimulus. And when someone's acidotic with a low pH, right, that's going to cause the SNS to fire off and they get these symptoms. Okay? The other thing that causes an SNS response, I'm not sure if you ever took a test or you ever asked out a boyfriend or girlfriend or boyfriend and you start getting palpitations, right? Those palpitations are getting diaphoretic and clammy hands, right? That's diaphoresis. You start breathing fast. If you probably didn't notice, but you were breathing fast, right? You had tachycardia, your heart was racing. And what does someone say when they have tachycardia? Someone doesn't come into the hospital or you don't call up your friends like, hey, dude, I got tachycardia. No, you're going to call up your friend and you're saying, I got palpitation. I feel like my heart's racing, right? Those are signs of fast heart rate, all right? So that means if you're making a chart or making a concept map, all your tachycardias have palpitations or heart racing as a symptom, right? They all have pretty much the SNS stuff too. They might be diaphoretic and breathing fast if they also have sinus tachycardia. Okay, the blood pressure will be elevated, and we'll talk more about blood pressure when we talk about cardiac for exam 2. But as a little introduction to it, when you have an SNS response, your blood pressure goes up. Right? We talked about beta-1 receptors in the heart. We have beta-2 and alpha-1 receptors out in the periphery on the vessels that will vasoconstrict and vasodilate, depending on which receptor you're at, and it will cause a net increase in your blood pressure. So when our blood pressure is low, over here somewhere, blood pressure is low, it tells your SNS, hey, you got to raise the blood pressure because the blood pressure is low. So increasing the heart contraction will help, but also it goes out to the periphery and vasoconstricts and vasodilates out there to help out. Okay, so cool, clammy skin. Why is your skin cool? We know why it's clammy because we have SNS receptors, or the SNS went out to our I'm trying to say saliva, but went out to our sweat glands and caused them to release sweat. I'm not sure why that helps us, but you got sweaty hands now. But why are your hands cool? So you vasoconstrict it, right? Blood not only carries oxygen, it also carries warmth. So if you don't carry warmth, if you're rerouting blood to the important parts, right? The important parts and what your body feels is important is your heart, your lungs, and your brain. So you're going to vasodilate those things at the beta-2 receptors, heart, lung, some muscles as well, like the diaphragm, for instance. And it's going to reroute blood away from the skin. So you have cool skin, right? When someone has an SNS response, they get cool and clammy. And it's the skin gets blood rerouted from it, and the skin is the biggest organ of the body, right? What's the biggest organ system in the body? The GI tract. That's why when you eat a huge lunch at Subway today, you're going to tune out afterwards because all the blood is now in your gut, right? Away from your brain, away from your primary sources. Unless you want to ask out your friend or you want to I tell you there's a quiz coming up or something, and then your heart rate's going to go up and now you're going to get some abdominal pain because how the blood's away from there and your gut's like, what about me? So yeah, so you're going to reroute blood away from that GI system. So you're not going to take all that blood away and push it into the central systems, right? The brain, which is important, your heart, which is important, and your lungs, which are important. And unfortunately, little divas don't get blood. So the body does not feel, it's objective right there. It says, you know what, you guys have alpha-1 receptors. When it comes down to it, we're going to take blood away from you. And they get upset and they're going to do their own thing, which we'll talk about. But that's the idea. When you have an SNS response, you're going to have cool, clammy skin, tachycardia, which we kind of explained in depth, and you have tachypnea. Your bronchioles will dilate, specifically at beta-2 receptors. We talk about the lungs later, okay? And then what else? So you get anxious. So when someone has SNS response, they usually have more anxiety. They have tremors. They have a feeling of impending doom. You'll see this on many, many NCLEX questions. They have a feeling of impending doom. It could be because they have a really, really fast heart rate, or it could be because their blood pressure is really low. It could be because their blood sugar is really, really low. It could be because they're really, really acidotic with their pH being really, really low. So all those things are a symptom of SNS activity, all right? And then pupil dilation, cool. All right, and then blood sugar. So your blood sugar will rise when you have an SNS response. That's one of your goals when you're running away from a bear. You want to have sugar for the muscles to run away from the bear. All right, so that's the whole idea of raising your blood sugar. All right, you want to keep the blood sugar operational for your brain as well, not only for your muscles, but for your brain, so you can actually run away from the bear intelligently, not just run into a wall. Okay, and we'll talk about more about the blood glucose and diabetes, because that's where we talk about glycogenolysis and gluconeogenesis and corticosteroids and such. So we'll talk about that more, and diabetes. Okay, so that's the nerve response. All these nerves go out to the different areas and cause that effect. But if we want to sustain that, like when you almost get in a car accident, you swing away, and you're in the median, and you're cool and clammy, you're tachypnic and tachycardic, and you have feeling of impending doom, and you feel like your chest is really, really tight. That's the reason why it sustains for like 10 minutes. Anybody got in a car accident? All right, anybody not had that opportunity yet? Anyways, so when that does happen, or you've almost got hit or something, then you feel like for 10 minutes you have to recover. It takes a long time to recoup. It's because your body has not only had that initial response, but you have all the adrenaline juices flowing through the body. And all that adrenaline juice came from the adrenal glands, right, on top of the kidneys. I don't have a good picture here, but the adrenal glands release norepi and epi, and that will then sustain the SNS response. Okay, and we'll talk about the RAS system later, but the SNS directly triggers the RAS system, the RAAS, and that all these things intertwine. When we talk about ACE inhibitors or beta blockers or all these other medications, we talk about cardiac, this is kind of what we're coming back to. So that's why I'm spending a little bit of time on these guys, right? ADH, antidiuretic hormone, is also involved, but we don't really have medication that affect it, but it will have be present in the body to help raise the blood pressure, for instance. When blood pressure is low, that will trigger the SNS response. It will trigger the RAS to raise the blood pressure. It'll trigger ADH to raise the blood pressure as well. And we'll talk a lot more of these when we talk about CHF for exam 2. And we really have to manipulate all these different systems. But we're going to focus on the SNS because that's going to affect the heart rate and all the things that are stimulus right here for the SNS will raise the heart rate, right? So if someone has pneumonia, right? They could have sinus tachycardia. Someone has a pleural effusion, pulmonary edema, that could cause atrial fib if they have a heart that has scar tissue or is dilated, right? It could cause VTAC when you have pneumonia. So what's the underlying mechanism or underlying mantra here, or what's the word I'm looking for? Underlying thing here is that hypoxia of any variety, right? You don't have to memorize pneumonia, pulmonary edema, pleural effusion, pneumothorax, and asthma, and COPD, and emphysema, and chronic bronchitis, and COVID-19, and influenza A, influenza B. No, hypoxia, right? If their O2 is low, they will have a fast heart rate. That's end of story. That is the key takeaway, right? If blood sugar is low, heart rate fast, right? That is what's going to happen. You could say, oh, they got Lantus insulin, they got Detamir insulin, they got Aspart insulin, they got MPH insulin, they got, they got a glycogenolysis storage disease problem that's genetic. As long as it causes hypoglycemia, I have tachycardia, right? If my CO2 is elevated, I have emphysema, I have decreased respirations, hypoventilation, I have anything that makes my CO2 high, tachycardia. That's it. End of story. Right? So you don't have to memorize all these little things. As long as you understand the operational paradigm, I can't think of the simple word, but what's the word I'm looking for? A puzzle piece, right? That's going to clue you into what is causing the tachycardia, right? As long as you understand the normal physiology, you can get to the right answer every time. So someone's like really, really tachycardic in front of you, why are they tachycardic? Well, it's one of these things. Something's causing one of these things to happen. Okay? They could be exercising in front of you. They could be increased movement. And you can rule that out real quick. So, well, it's probably not because they're moving fast, right? That's probably not why they're tachycardic. Or when you're like, your friend comes up, it's like, why are you breathing so fast? Oh, I took the stairs. Okay, that makes sense, right? The reason why they're breathing fast, you try to catch your breath, you go, I'm trying to breathe slow, but nobody notices that I have, I'm out of shape. Okay? So that's the idea behind this. All right, her SNS was firing on all cylinders. All right, so after she gets back inside, like, oh shoot, I pushed a bear, and she's gonna feel about for 10 minutes. She's gonna feel a little norepi surge. All right, so the pacer. So we talked about all that little overview slide, had the autonomic system, the medications, the electrolytes. So we're gonna go a little bit more detail on one of those things because we're gonna talk about the medications after this. Okay, so the pacer, the ANS, which we kind of talked about in depth, but it is what's causing the action potential to go off on its own. And we have two action potentials in the heart. We have the pacer, which is spontaneously always going off at a certain intrinsic rate, and we can suppress that, or we can not suppress that and make it easier for it to reach thresholds, right? So when it reaches threshold right here, the light switch is on. That's a stimulus that's going to spread cell to cell to cell, all right? So here example is the cardiac action potential. We got sodium and calcium influx into the actual cell, and sodium and calcium are hot water, right? So that hot water, when it goes into the cell, when we open up those channels and those electrolytes go across that cell membrane, it's going to depolarize that cell. And that stimulus will be the stimulus for the cardiac action potential. Okay? So the pacer's going off on its own thing. It's doing its own thing, right? Because when it's actually finishing over here, this one's just beginning on the right, right? So on the left, just to complete the story, we got potassium efflux, right? And what is potassium? It's cold water, right? So when I have a really high potassium level in my body, my potassium level is 7.2. That's going to that's going to want to go across the cell membrane because of diffusion, and therefore at rest, it's going to cause this to be hyperpolarized, right? So this stimulus, this pacer potential finishes, and then we're going cell to cell to cell to cell, and we're depolarizing it through the whole heart. And if it's in the atria, we get P waves. If it's in the QRS, if it's in the ventricles, we get a QRS complex, right? And they repolarize too. The movement actually of changing polarity can actually cause a T wave, right? So that's the idea. So calcium is influxing because when calcium influxes, yes, it's hot water. So it's going to maintain that little plateau phase. But also the calcium, you need that calcium inside the cell because inside the cell you have muscle contraction, right? And that muscle will contract when calcium enters as well. Okay. So here's a normal SA node firing off at 60 to 100 beats per minute. And then we want to increase the heart rate. We got to make the threshold what? We're going to make it a little closer to threshold, and it will go off faster, right? So we depolarize the baseline, right? How do we make that baseline hotter? How do you make your bathtub, your heart temperature hotter? Well, you can make it so that there's more sodium entry at baseline. You can make it so there's less potassium entry at baseline, and that's what these medications do. They will alter those things. They will open up more channels or close more channels, okay? So what else on that? We can hyperpolarize it as well. So if we hyperpolarize, we can make it, someone has hyperkalemia, or someone has increased vagus nerve activity because they took digoxin, right? That's going to cause the heart rate to be less. So we count the number of blue peaks there, that's 3, right? Compared to the number of black peaks, which is hard to see now, but we got what, 1, 2, 3, 4-ish, that's less, right? So that's the idea here. That's what the sympathetic fibers are doing technically, and that's what the vagus nerve is doing. It's going to cause that depolarization, and then we get that depolarization as a stimulus for the cardiac muscle to then depolarize and therefore contract. Electrical activity precedes mechanical activity. All right, so there's our SA node right there, and it's firing off cell to cell to cell, and that's going to depolarize the next cell, and that's going to depolarize the next cell. That's the stimulus that spreads to the whole heart until it hits the what? What is it? So it's SA node's firing off, and it spreads cell to cell to cell to cell to cell, and then it's all going to stop where? At the AV node, right? The AV node is the gatekeeper between the atria and the ventricles, and it will allow one impulse, hopefully, through, right? If there's multiple impulses like AFib or A-flutter or SVT, it's only going to let certain ones through. If it's letting everyone through, you got to tell them, you know, we need to stop that. We need to suppress you, right? You're letting way too many people in. You're not a good bouncer, right? So you're going to suppress them, right? With masking tape, I don't know. No, you're going to be using a medication. That's going to be an AV node suppressing agent, right? Right? So we have AV node suppressing agents that will suppress the AV node and let less impulses through. Therefore, any kind of AV node suppressing agent is going to cause what kind of side effect? Bradycardia. End of story. It causes bradycardia because it's suppressed the AV node. The only way you got an impulse through was through the AV node. So if I suppress it, I'm going to have bradycardia. And usually every one of those AV node suppressing agents has a, framework or a hold parameter, right? It says hold if heart rate less than 50, hold if heart rate less than 55. Or someone's on an amiodarone infusion through their IV and their heart rate's 42, it's like, well, shoot, I should probably hold the amiodarone. That is causing, that's an AV node suppressing, that's suppressing the AV node, and it's going to cause a bradycardia as a side effect. The intention was to lower the heart rate, right? They probably had a high heart rate before. Okay. All right, so SA node pacemaker potential, sodium calcium is the hot water that's causing that impulse to spread. That's the stimulus that's going to cause it to, that cardiac action to go off. And this cardiac action potential right here, this little positive stimulus is go to the next cell. And then each is going to carry all the way down. And again, now the next part of the story is calcium, right? So the impulse spreads across this membrane here, and it's going to hit a little receptor, right? It's called a DHP receptor, or a dihydropyridine receptor. The only reason why I say dihydropyridine is because the medications that all end in dipene. The reason why all these medications end in dipene is because they are dihydropyridine receptor antagonists. They block that little receptor. If you block that receptor, calcium does not get through. They're also known as calcium channel blockers, all right? And the reason why I bring up DHP or dihydropyridine is we have two varieties of CCBs, two varieties of calcium channel blockers. We have non-dihydropyridine and dihydropyridine. We have ones that block the calcium, this little channel right here. We have ones that don't, all right? So we'll explain that a little more, okay? So that's the idea behind the cardiac action potentials. They are the stimulus that goes to the next cell, to the next cell, to the next cell until it hits the AV node, and then one impulse gets through and it goes down the ventricles. Again, same thing, cell to cell to cell to cell, and then we're in business. And then we get the contraction of the heart. All right, so you can see we have an impulse right here. There's a little SA node. We got an impulse right there. There's that one. We got a little one right there. There's that one. It's going all the way through the ventricles, and eventually they're all going to even out and become what's known as isoelectric. Isoelectric is your baseline impulse, or your baseline resting membrane potential. When there's no cardiac activity, no electrical activity, you're asystole and you're dead. But also, we will hopefully have a little SA node fire off, and that's our P wave, right? And then we get the QRS goes off. So we have this, we have an isoelectric line that is important because we measure all of our intervals. Every single interval we measure is always isoelectric to isoelectric, right? When people want to measure like a QT interval, they're like measuring to the top of the T. It's like, what are you doing? It's always isoelectric to isoelectric. You measure a PR interval, they're measuring like the top of the P to the R. No, it's PR, it's isoelectric to isoelectric. It's actually before the P to the R. Sometimes it's a little tricky. You can say QT, is it before the T or after the T? And it's after. But there's a few little memorization pieces like that. But whenever you measure intervals, like a QT interval or a PR interval are the important ones. A QRS interval. A QRS interval is not Q to S. No, it's isoelectric to isoelectric, right? That's the QRS interval. I measure a P wave length and T wave length, really not too important nowadays, but if you measure a T wave, you would measure isoelectric to isoelectric, right? Usually the one we like is the QT interval, which is Q to T. That's our QT interval. And that's one tells a lot of information about the way the heart is repolarizing. Because the heart has delayed repolarization, right? The whole purpose of repolarization is to get us back to normal. But remember, we're switching that light switch on and off, on and off, on and off. We have an area that we are at risk for a lethal rhythm. Right, if you have an impulse that is right there, as the white light switch is going off, we can go into a lethal rhythm. That lethal rhythm is called torsades, right? So for instance, we have a PVC, a little PVC right on that T wave, right? A T wave signifies that area where we are at risk, right? T wave is ventricular repolarization, and as we are coming down off that T wave and we have a little PVC there, or you have something that's going to interrupt that cardiac cycle, that can cause you to go into a lethal torsades or lethal cardiac rhythm. All right, so torsades de points, if you're French. All right, so that's a lethal. That's one of the important causes of torsades. There's other causes of torsades, like we mentioned, low electrolytes, right? Low calcium makes you more ectopic, makes you more at risk for PVCs, more at risk for little runs of SVT or little runs of AFib. It makes you more depolarized when your potassium level is low or high. Low. Same thing with calcium, same thing with magnesium. Calcium's low, mag's low, K is low. All those things put you at risk for PVCs and PACs, and then that puts you at risk for a torsades if you get a PVC right on top of your T wave. All right, so here we got, like in sports, this happened about 2 years ago, and then I got like 3 messages from nursing students like, what happened, what happened? All right.
Pro football player Damar Hamlin recently suffered a cardiac arrest. Thankfully, he was resuscitated. But what exactly happened? Well, we don't know for sure, but I suspect something called commotio cordis. This is rare. It's when the heart stops beating, not because of a heart attack. There's no damage to the heart muscle itself, but rather a forceful impact occurs on the chest wall at just the wrong time to disrupt the heart rhythm, putting it into ventricular fibrillation, cardiac arrest. This is so rare because there's only a tiny window of time when the heart is vulnerable. It's really only 40 milliseconds during the ascending portion of a T wave on an EKG. An impact at any other time during the cardiac cycle won't lead to cardiac arrest.
All right, so that's a new fear unlocked. All right, so that's that's the vulnerable part of our heart. It is much more rare for it to get hit in the heart, but it's more likely when we have like a PVC or when we purposely shock the heart back into a normal rhythm. And what is that called when you shock the heart purposely? It's called cardioversion, right? So when someone has no pulse, you don't care. You're going to shock them, right? But when someone has a pulse, you don't want to put them into a rhythm that has no pulse, right? So that's called synchronized cardioversion when you are synchronizing to the R wave. Actually, the R wave is a big impulse right here, right? We're synchronizing. We're doing synchronized cardioversion for patients with a pulse. And the reason why we're synchronizing is so that we don't shock them on the T wave. The machine is intelligent enough to just do that for us. Okay, but if someone has no pulse, we might just shock them whenever, right? And there's only certain rhythms we do shock. So that's one of the things we can talk about cardioversion. You make a quick table, like do I shock or not shock? It's based if they have a pulse or no pulse. And if they have no pulse, it's based on what the EKG is showing us, right? For instance, if the EKG is showing no rhythm whatsoever, it's asystole, shocking is not going to work, so we don't do it, right? All right, so calcium. And calcium channel blockers, right? So calcium, remember the cardiac action is going cell to cell to cell to cell, and if we zoom in on the cell, we look in there, that little impulse, right, is going to trigger the DHP receptor. And when you trigger that DHP receptor, calcium gets released from its storage area, which is the sarcoplasmic reticula, but it's going to, that calcium get released, and that calcium is going to then contract the muscle, right? The heart's going to contract. So if I have a calcium channel blocker that blocks the DHP, is their contractility going to be more or less? Less, right? So when someone has CHF or an MI, probably not a good idea to give someone a calcium channel blocker, right? That would be a contraindication. If someone has a really bad CHF, right? CHF stands for what again? Congestive heart failure. If a heart's failing, let me give you medication that makes your heart fail more, right? It's going to decrease, what's the word? Fancy word? Inotropy is contractility, right? We're going to decrease contractility when we give someone a calcium channel blocker. So that's one of the contraindications for calcium channel blockers, right? So calcium affects the cardiac action potential, so it's what's maintaining its plateau phase and such, but it also is affecting the contraction of the heart. So if it's a DHP calcium channel blocker, it's affecting the contraction of the heart, right? And if it's a non-DHP, it's not affecting the contractility, it's really just going ahead, it's just affecting the SA node and the AV node. It's just affecting calcium entry into the AV node. And calcium entry is what? Hot water, right? So if we reduce the hot water entry at baseline, that's going to make our membrane what? Lower. So therefore they have a low heart rate when you get a non-DHP calcium channel blocker. Okay? So non-DHP calcium channel blockers, and there's only 2 of them, right? And those 2 meds are called diltiazem and verapamil. So they don't end in dipene. Everything else ends in dipene. All DHP calcium channel blockers end in dipene, which is nice, right? Like amlodipine, nifedipine, nimodipine, nicardipine, right? All these one end in what? Dipene, 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 dipene. All right, so these dipene are the DHP calcium channel blockers. They don't affect the SA node and AV node. They affect the contractility of the heart, and the contractility of other muscles, such as what? What are the 3 types of muscle fibers in the body? It's like, shoot, that's about all the way back to anatomy. Skeletal muscles, so guess what? Patients that take calcium channel blockers that are DHP, dipene, feel fatigued. Why do they feel fatigued? Because their skeletal muscles don't work good, because you just blocked it with the medication, right? And then what else, what other muscles do you have? We already talked about cardiac muscle. They got a decreased inotropy. What else? Smooth muscles. Where do you have smooth muscles at? Next semester, you're worried about the uterus. Right now, we're not worried about the uterus just yet. But when someone has active labor, it's like, it's not time yet. It's only 30 weeks. Let me give you a calcium channel blocker to slow down the uterus, right? But besides the uterus, where else do we have smooth muscle? You got vessels, right? You got blood vessels, and the blood vessels contract, and that's called what? When a blood vessel contracts? Vasoconstriction, right? So calcium channel blockers cause no. Calcium blockers block calcium entry into the muscle so it cannot contract, right? So it causes vasodilation. So all these ones that end in dipene are for hypertension, high blood pressure, right? They have no effect on the heart rate. They only reduce contractility of all the muscle fibers in our body, okay? So because we vasodilate, we get a low blood pressure, right? And because we vasodilate, we get peripheral edema. Why do I get peripheral edema? Well, your vessels are like a Chinese finger trap. When you open it up, it gets leaky, right? So they get edema. They also get a headache. Why do they get a headache? Because you're vasodilating in a skull, which is a box, right? You're putting more pressure in the box, you're going to get a box pain, which is called a headache, right? So you get a headache, you get peripheral edema, you get fatigue, you get a low blood pressure. That's all of our side effects, aren't they? Of a calcium channel blocker. That's specifically the dipene ones. The other ones, the other two have more unique side effects, or just like bradycardia. Okay, so that's the idea. When you understand meds, you just figure out why it has a side effect, right? It's very rare where it'll just a side effect is not explainable. Okay, well, you can always say it causes nausea, vomiting. It might cause a little bit of diarrhea, maybe. Right? That's always a good answer, but really what is like a specific side effect. Like if you look in your drug book, it's going to have every single reported side effect known to man that's ever happened, right? That doesn't help you. You have to know the side effects that are important that you're actually going to see, okay? So there's 2 classes of calcium channel blockers. We have the DHP and the non-DHP. The reason why we delineate them is because of side effects, right? The non-DHP side effects are not going to lower your blood pressure. Yes, they could lower your blood pressure if your heart rate gets way, way too low, but that's not their primary effect, right? So we got non-DHPs. Talk about those first because non-DHPs don't affect the DHP receptor. Where's the DHP receptor found? Cardiac muscle, smooth muscle, skeletal muscle, right? So there's only 2 of them, which is decent, right? And they don't have the same last name, which is not decent, but they have rapamycin and diltiazem. Whenever you hear diltiazem, it is used to lower someone's heart rate. When you hear rapamycin, it's used to lower someone's heart rate because it's blocking calcium entry at the SA node and AV node. That's all it's doing. It's not blocking the DHP. It's a non-dihydropyridine calcium channel blocker, a non-DHP CCB, right? Its goal is for arrhythmias. When we come back to hypertension in 3 weeks, whatever it is, for exam 2, we're going to come back to DHPs, to the dihydropyridines, because those ones are for blood pressure. Non-DHPs are for what? For arrhythmias, fast or slow ones? Fast ones, right? Ventricular or supraventricular ones? Supraventricular. Why? Because these affect the calcium entry at the SA node and AV node. If I have a ventricular rhythm, that's something going on over here. That's not have no effect on it, right? It's out of its wheelhouse. But if I suppress the SA node enough with a non-DHP calcium blocker, blocking all the calcium entry, making it more hyperpolarized, making it harder to reach action potential, letting less things through, that's going to help fix SVTs, supraventricular tachycardias, or atrial tachycardias. And we'll define what atrial tachycardias are, but this is how this medication works. So we talk about those medications later, and we say, oh, is it non-DHP or DHP calcium blockers? It is, which one affects when someone has a high heart rate? Which one do you give? Non-DHP or DHP? Non-DHP, right? So there are 2, and one has a little bit of mixed DHP effect. We're not really getting into that, but both these guys are going to lower the heart rate, right? That is the side effect of these medications, right? Their action at the SA node is lower heart rate, And an AV node, decreased conduction. It's an AV node suppressing agent, right? It's one of our 4 AV node suppressing agents, okay? So DHP, calcium channel blockers, that was non-DHP. I'll just spend a second on DHP ones. Again, DHP is where? That's at the, in the heart right here, right? That's a cardiac action, that's a cardiac muscle right there in the bottom right. And when we give a calcium channel blocker, it's gonna block calcium entry into that muscle and therefore make that muscle weak because we have less calcium to contract, okay? So DHP, calcium blockers block DHP, right? They are calcium channel blockers, right? And the nice thing is they all end in the same suffix, which is dipene, right? So we have amlodipine, nicardipine, nifedipine. We have all kinds of, it ends in dipene. It is a DHP calcium blocker, and you can think to yourself, well, shoot, it's gonna vasodilate because my muscle can't contract. I'm gonna get fatigue. I'm gonna get headache. I'm gonna get peripheral edema. Am I gonna get a low heart rate? Or a high heart rate, or no effect on heart rate? You're gonna have a high heart rate. So if you overdose on a calcium channel blocker, that's a DHP one. It's impossible to have a low heart rate. Why? Because you have to know your physiology, right? So if you vasodilate in your periphery, all the blood just dumps in the periphery, right? And none of the blood returns to the heart, right? If no blood returns to the heart, your baroreceptors are now going to fire off, right? Your baroreceptors detect blood pressure. When your blood pressure is low, that does what? That goes to the brain. Say, hey, the blood pressure is low out here. What are you going to do about it? So what's your brain going to do about it? It's going to send an SNS signal down and raise the heart rate, right? It's also going to try to vasoconstrict that periphery. But you have calcium channel blockers there that are stopping that from happening. So we can reverse that with glucagon. So glucagon is a reversal agent for calcium channel blockers. All right, so you have reflex tachycardia. All right, you get vasodilation, like we mentioned. It's going to have peripheral edema. They're going to have a headache as well, right? Also, if you vasodilate, that's the primary intention of this medication, to vasodilate and lower someone's blood pressure that's high, okay? And they get reflex tachycardia because the SNS is firing off because the blood pressure is too low, all right? And it's also going to decrease contractility. It's decreasing calcium entry into all the muscles. So it's not for CHF patients. So if you have a CHF patient that's on this, you have to have a really good reason or it was an error, right? So that's, you want to avoid this medication when someone has CHF, especially if their ejection fraction, which we'll talk about in cardiac, is low, less than 40%, okay? Also, someone that has ACS. What is ACS? Acute coronary syndrome. And we'll talk about this in exam 2 for cardiac. But that's someone who's having an active heart attack, right? Someone's having an active heart attack. Hey, let me make your heart work less for you, right? That's probably not a great idea. Okay. Can I give someone with a heart attack that has a high heart rate, like verapamil? You could, because it's not going to reduce contractility. Okay. And if you open up your drug guide right now and you look at amlodipine, it says bradycardia. It's like, well, shoot, why does it say bradycardia? I thought the professor told me that it was tachycardia. It is tachycardia. It does not cause bradycardia. It did cause bradycardia in someone micro, right there down in Mexico. That guy, he developed amlodipine. He was a monk at the top of the mountain. He's like, oh, shoot, I take amlodipine for my blood pressure, and I got a low heart rate. Well, F.A. Davis, let me write this down. Bradycardia is a side effect of amlodipine. It is not, right? It's reflexive tachycardia, right, is the side effect for all of our DHP or non-DHP? Our DHP calcium channel blockers. They all cause vasodilation, they all cause headache, they all cause fatigue, they all cause bradycardia? No, they all cause reflexive tachycardia. All right? So if you take too much of that medication, then we can reverse it with glucagon. Okay? Does that make sense how that works? And again, it's like, why you tell me all this crap? Why don't you just tell me what the side effects are and we can move on to the next slide? Well, you could memorize this. You could just say, okay, you guys, amlodipine, it's going to cause reflexive tachycardia. And verapamil, it's going to cause bradycardia. Next slide. That's how you're going to learn that? No. So you have to understand the why. But don't get lost in all the details. I'm not going to test you on how it causes fatigue, right? It's because the skeletal muscle DHP receptors are blocked, and then therefore the calcium can't leave the sarcoplasmic reticulum, it can't bind to the actin-myosin or astrocytes, and then it can't displace. No, that is physiology. That is not the nursing exam. The nursing exam is patient complains of fatigue and headache and peripheral edema. Which medication might they be on? Well, and it wouldn't be verapamil, right? It would be which? Any one of the ones that end in dipene. Okay? That's the idea behind understanding the material. Yes?
Is glucagon a reversal for DHP and non-DHP?
It's more for DHP. And again, yes, that's true, but I'm not going to test you on that. I'm not going to say is it DHP or non-DHP, right? You are new nurses. I'm not going to test you on little fine details. I'm testing you on big things that are, important side effects, important teaching, things that get tested on all the time. And how do you know if it gets tested on all the time? Well, NCLEX questions are a good source, right? Because if you go to 3 different NCLEX books and they all ask about hypotension with, DHP calcium channel blockers, that's probably what we're going to ask you also, right? All right, what else? So here's an example of calcium channel blocker right here. So here's this DHP receptor is trying to be activated. He's like, no, stop it. So there's our calcium channel blocker right there. All right, which kind? A DHP calcium channel blocker. So he's going in there and he's inhibiting the DHP receptor. Stop it, right? So, all right, so electrolytes. So back to electrolytes. So again, it's hot and cold water. We're not going to spend too much time on this, but this is, again, if you have too much potassium, right? That's too much cold water. Therefore, that's going to make my membranes cold at rest, and it's make it harder to reach threshold, and therefore I get bradycardias, right? So high potassium levels cause bradycardias. Low potassium levels make you more irritable, more at risk for ectopic foci, ectopic beats, such as PVCs and PJCs and PVCs, oh my, right? So it's arrhythmogenic when your potassium level is low. That means you're at high risk for arrhythmias, you're high risk for torsades, you're high risk for VTAC, you're high risk for tachycardias, high risk for little runs of tachycardia, like 10 beats, 12 beats, whatever it might be, okay? And then you can block potassium channels. So before I think I said potentiates potassium channels, the amiodarone blocks potassium channels. So if I block potassium channels, how does it make my membrane colder, right? Well, you're increasing the duration of the action potential. So here we had a normal action potential, and the red line, we are blocking potassium channels, making it more difficult to come back down to normal, okay? So that means less impulses can be provided, right? If you're in VTAC, for instance, you're going at 200 beats per minute, right? We can widen that out so less impulses can be activated, right? Because the light switch has to be off before you can turn it on again. So you're making it where it's like someone like holding your finger up while the light switch is on, right? So that's the idea behind amiodarone. Adenosine opens all the K channels. It just opens all the K channels, makes everything cold, it turns off the heart, and it only lasts for 8 to 10 seconds, and then adenosine's gone, and then now your heart can hopefully reset itself, okay? Low MAG is going to cause low potassium side effects because you need MAG to absorb your potassium in the kidneys. So if you have low MAG, you're going to have low K symptoms also. All right, so it's just it's just the same thing. Okay, and then sodium is hot water. So if you open more sodium channels, that's the same thing as like increased SNS activity. So that's the idea. So you're going to be tachycardic. Right, you can block sodium channels. There's certain medications that block sodium channels, and that will cause bradycardia. All right, and also you have sodium channels in your SA node and AV node, and if you block those, that's basically what you've really done. If you zoom in all the way, yes, norepinephrine binds the beta-1 receptor and causes bradycardia, but how did it cause bradycardia? It causes tachycardia. If you give beta blocker, it's blocking that sodium channel from activating that SA node or AV node, what have you. Okay, and then calcium. So calcium, similarly like MAG and potassium, is going to, if we block calcium is hot water, we're going to get a bradycardia. And that's what your DHP or your non-DHP do. At the SA node and AV node, they're blocking calcium entry. Your non-DHP are going to cause bradycardias, right? All right, so what else? So you have too much calcium. It's like, well, that's too much hot water. Well, you can destroy the potential, and you can actually cause the heart to stop and become bradycardic. Okay, so you have hot water here, and we got cold water there, and that's kind of the best way I can explain when you talk about resting member potentials and increase and decrease of sodium channels and open. You think of what the channel's doing normally, and if it's open, more of them are open, and it's letting more cold water in, I'm going to have a bradycardia. Okay, so here's an overview of our meds. We've already talked about which one? Non-DHP calcium channel blockers. We kind of touched on amiodarone a little bit. It's a K channel blocker, right? And it's going to decrease heart rate by prolonging the resting membrane potential. It makes this membrane potential longer, so less impulses can get through. So if it was right here, right, if I have 6 impulses getting through, and if I prolong this, now less impulses are getting through. Okay, that's the idea behind amiodarone. And the downside of that is it prolongs the QT interval. QT interval is remember this little downstroke right here was the beginning of that T wave. If I prolong that, that's going to make my QT interval prolonged. So one of the things we monitor with amiodarone is the QT interval. Right? So it's very important you monitor the QT interval, because the QT interval gets longer and longer and longer. What happens? You get torsades. That's another important cause of torsades, is QT prolonging agents, medications that prolong the QT, and amiodarone is one of those. Connecting to Zoom. Zoom lost connection. All right, put that in the corner. All right, anyways, so we got amiodarone and then adenosine. Adenosine is usually a one rhythm drug. It can be used for other ones, but really the rhythm I want you to know it for is PSVT. And why not just say SVT? The P is important. All right, the paroxysmal SVT, which we'll talk about in more detail. The paroxysmal SVT is there when it's a really, really fast heart rate. And what you want to do is you want to kind of reset the heart. And to reset the heart and turn off that really fast heart rate is you're going to give adenosine. It lasts 8 to 10 seconds, shuts everything down, and then it reboots. And hopefully it's at a heart rate that is acceptable. Okay, and it does that by being a potassium channel agonist. It binds all the potassium channels, opens up all the cold water it can in the heart, and it turns it off. It just lowers it to nothing. Okay, and then beta blockers we'll talk about more on the next slide, but beta blockers all end in LOL, which is nice. So sorry, this Zoom lost connectivity, so let's just share that again. And oh, it's still recording at least. Good. All right. So anyways, beta blockers all end in LOL. There aren't like non-DHP or DHP beta blockers. Beta blockers or beta blockers or beta blockers, except there are some that affect just beta 1 and some that affect all of them. All right. So there are beta 1 specific ones, and there are ones that affect beta 2 and alpha 1. Which ones do you think are for the heart, or for a abnormal heart rate? That might be fast. Beta 1 specific, right? Because you have one heart and 2 lungs. You got beta 2 in the lungs. You got beta 1 in the heart. So beta 1 receptor blockers are the ones that are going to be given for fast heart rates. Okay, we'll talk about those in the next slide. We talked about non-DHP calcium blockers already. It blocks calcium because it's a calcium channel blocker. And then we have DIG. We have a slide dedicated to DIG as well. And DIG is going to block a little exchanger, and it's actually going to reduce heart rate. We'll talk about how it works. And DIG actually is going to increase contractility. So patients with CHF, they might get digoxin if they have a really fast heart rate. Okay, so these are the ABC drugs, A, B, C, D. So adenosine gets a little A because it's only used for one arrhythmia. But A, B, C, and D, so A for amiodarone, B for beta blockers, C for non-DHP calcium blockers, and D for digoxin. These are our medications that we will be manipulating that you have to understand. You have to understand what these medications are for, and all of these medications are for fast heart rates, right? Only one of them can be used for ventricular rhythms. Which one's that? Do you know? Do you think? Adenosine is used for PSVT, right? PSVT only. When someone says PSVT, treatment is adenosine, right? But only one of these works throughout the whole heart, right? Not just on the SA node and AV node. So beta blockers work on the SA node AV node. Non-DHP CCBs work on just the SA node AV node. Digoxin works in the SA node AV node, as we'll come to find out. It actually potentiates the vagus nerve. Amiodarone, right? You're blocking K channels throughout the whole heart. So it's for atrial and ventricular rhythms. Amiodarone is a jack of all trades. It does a lot of things, right? So that's the idea, is to understand the indications for these medications, like when would this medication be indicated? And you call the doctor and say, hey, doctor, they have PSVT, right? Or let's make it easier. They have AFib, and the heart rate's like 150. It's like, okay, go ahead and give digoxin. That checks the box. Yeah, the digoxin would be indicated, but they said atropine. It's like, well, A is an atropine. Atropine's not on this list. Atropine's for low heart rates, right? So you got to make sure it checks out. Someone has like VTAC on the monitor. Doctor says, okay, just go ahead and give, diltiazem, right? So diltiazem affects the AV node. It's not going to have any effect on ventricular rhythms. So you want to know like which ones are, what these medications are indicated for, all right? So anytime you understand, when you would learn a medication, you have to know indications for it. Knowing the class is really important because if you know the class, usually they like LOL, they all end in LOL if they're beta blockers. And that will give you, and then you have to recognize, well, it ends in LOL, that's a beta blocker, and it's indicated for supraventricular tachycardias, right? And then the next thing is side effects, right? You want to know for every medication ever are side effects. And I'll write this on the board as well, sorry. So you want to know like indications, right? First you want to know what the class is, because the class will tell you, hopefully it has a suffix on it. If they have a good class, has nice suffixes, and they all end in LOL, or they all end in, like when we get to ACE inhibitors, for instance, which are not for the arrhythmias, but they all end in PRIL, right? But beta blockers all end in LOL, whether it be for hypertension or be for tachyarrhythmias, okay? You know the indications, you want to know what the side effects are, right? You want to know what the, that's it, right? Side effects, and then nursing interventions. Okay, I feel like I'm missing one. Either way, so you want to know what it's for, right? Is it for atrial rhythms? That checks a box. Patient has atrial rhythm. This is a good medication to give, right? Patient has a ventricular rhythm, and those medications are for, those other ones are for atrial. I should probably question that order, right? And then side effects, like, well, shit, I can't question the doctor. What the heck? I'm a nurse. What does that mean? No, you are a team. You're a team of healthcare providers, and your goal is to, make sure the patient is safe, right? So you are allowed to question the doctor. That's the whole point of being the nurse, of being the RN. And there's no shade at LVNs, but LVNs are trained to give PO medications, trained to give sub-Q medications, trained to do a lot of good procedures, and LVNs are great at doing procedural things. Whereas the RN knows that RN is also trained all those things. Some of them can be great at things, some of them not so great. Like those, this is how you put a Foley in. That's how I learned to put a Foley in. Either way, so you have RN does all the things that LVN does, but also the RN is going to question things. The RN knows the side effects. The RN knows the indications. The RN knows the teaching, right? LVNs technically are not supposed to teach. They can teach instructions that have been developed by an RN, but they cannot like just start saying things from left field. It has to be clearly outlined. That's from the Board of Registered Nursing in California, right? So that's the idea behind what the RN does. You have to know these things, right? It's like, well, why is he teaching me all these things? Like, well, you could just memorize all these things, but you could also, you have to know the reason why you're doing what you're doing, okay? So why do I get in that tangent? Anyways, nurse interventions and indications, and you have to know, of course, a side effect. So these are for medications, right? We talk about disease processes, it's a little bit different, just like a few more columns you got to add on. But otherwise, that's the main idea. Okay, so what else? So we have, those are medications for the heart. All right, so we'll talk about the two other medications and we'll take a break. All right, so beta blockers and digoxin. All right, so beta blockers, what are beta blockers for? So they can be for high blood pressure, right? They are going to block alpha-1 receptors. Like, well, that's not a beta blocker. Well, they actually do, they kind of double dip, right? They could block beta-2 receptors. They cannot block beta-1 receptors. But we also have ones that are specific for just the heart. And those are beta-1 specific beta blockers. And those ones are all under the mnemonic of man-babe. So here's a man-babe. Some of you might have man-babes in your life too, right? So man-babes are beta blockers that specifically lower the heart rate. Their goal is not to lower the blood pressure. Their goal is to lower the heart rate because they only block beta-1 receptors. They don't block alpha-1 and beta-2. They only block beta-1, okay? So heart rate reduction beta blockers are man-babe. What is man-babe? That is over here, right? Metoprolol, atenolol, betoxolol. They don't use that as much, but bisoprolol we use a lot. Esmolol we use a lot. So if it doesn't fit on man-babe, it is a mixed beta blocker. It's non-specific. It doesn't just do beta-1, it does beta-1, beta-2, and alpha-1, okay? So those ones are carvedilol, labetalol, propanolol, nadolol. Those guys on the side there are probably for blood pressure, right? Because they are doing all the things. They're blocking the SNES on all fronts. They are higher risk for bronchoconstriction for asthmatics. They are higher risk for masking hypoglycemia symptoms because they are doing all the things, right? They're blocking all of the SNS activity. That's all the beta blockers do is block SNS activity, Okay, and SNS goes to the SA node, it goes to the AV node. So if we block it there, we're going to get a low or high heart rate. You get a low heart rate. Okay, so they block the SNS, and we get a low heart rate. And then when we talk about CHF for exam 2, we'll talk about the other reason why they're great is they stop the heart from being remodeled, right? Your heart thinks it knows how to make a heart, but it's just like when you hire a contractor who underbids the other contractor who costs $1,000 more, right? They're not going to build cabinets that look anything like cabinets, right? They're going to say, yeah, look, I know how to make cabinets, and there's the cabinet, right? So in CHF, your body is going to try to repair the heart, and heart failure gets worse if you don't take beta blockers, because you're going to stop the SNS from rebuilding the heart and making a shoddy heart. Okay, so we have, when we come back to beta blockers in CHF, there are specific beta blockers. Your patient's on metoprolol, or bisoprolol, or carvedilol. One of those 3 beta blockers is because they have CHF, or they have a history of acute coronary syndrome. So there's 3 specific medications. So we'll come back to that when we talk about heart stuff. Okay, so they also block the RAS, which is important for CHF as well. Okay, but side effects are side effects are side effects. It doesn't matter if you have a man babe or non-man babe. The side effects are low blood pressure. Now, which one's going to have the most effect on low blood pressure is going to be the ones that are mixed. Okay, not as prominent with man babe. For the beta 1 specific ones, beta 1 specific only affects the heart rate. And why would that have less effect? Why would just lowering the heart rate lower someone's blood pressure? Because what's the formula for cardiac output? Stroke volume times heart rate, right? So stroke volume is how much blood comes out of my heart, right? That can be, they could have CHF, they could have all kinds of things affecting that, but it's stroke volume times heart rate. If I eject blood from the heart 60 times a minute versus 120 times a minute versus 20 times a minute, one of those things is going to have less output, less blood pressure, okay? So bradycardia is a side effect for everything, whether it be man babe or non-man babe. Right, again, caution with diabetics, caution with asthmatics and respiratory patients, because it's going to suppress those symptoms, and also is going to cause bronchoconstriction. And we'll talk more about the hypoglycemia piece when we talk about diabetes. Okay, the nice thing about this one has the same reversal agent as calcium channel blockers, glucagon. So someone overdoses on beta blocker, someone overdoses on a calcium channel blocker, glucagon would be a reason or a medication we give to reverse it. Okay, so that's the idea behind beta blockers. All right, digoxin. So digoxin, remember we have what? A, B, C, D, right? So those are our medications that are used for lowering heart rate. Okay, and D is digoxin, and digoxin is going to lower the heart rate by potentiating vagus nerve activity. It makes more vagus nerve stuff happen. And what's the vagus nerve belong to? The SNS or PNS? The PNS, right? So the PNS is responsible for doing what on the heart? Lowering the heart rate. So if we lower the heart rate, right, increase vagal activity will happen, right? So increased vagal activity, which is what digoxin potentiates, gets low heart rate, okay? But it also increases myocardial contractility. That doesn't make sense. I thought if I have more PNS activity, I have decreased contractility. Well, digoxin also works specifically at these little exchangers, these little channels that exchange the movement of sodium and potassium in the heart muscle itself. It actually blocks that channel, and it makes it so more calcium stays behind. Because calcium has to leave when sodium leaves. And if we stop the sodium from leaving, the calcium is going to be more calcium will be behind. You have a really robust and prominent sarcoplasmic reticulum. You have more calcium available, and you have more contractility. Okay. So what else? So the other thing is with digoxin, you can get toxic with digoxin. So you want to know the dig level. If it's too high, you have dig toxicity. So that means you need to reverse it. Reverse with the glucagon. That'd be nice, but no. You reverse it with what agent? Digoxin Immune Fab, or Digibind is the brand name. And regarding brand names, so I'm not going to be testing you on brand names. I'm testing you on the generic names because A, the pharmaceutical companies have plenty of money. We don't need to advertise any more for them. But also B, the NCLEX is not going to test you on brand names. There'll be no brand name in sight, right? It's not going to say Primacor. It's not going to say, what's another, low pressor, right? That's not going to be on the NCLEX. So why would I set you up for failure. So I have to say labetalol, I have to say diltiazem, I have to say rituximab, or I have to say all these different, crazy long generic names that nobody knows, and none of your patients are going to know. He's like, okay, I'm here for your carvedilol. Like, what the heck's carvedilol? Your Coreg. Oh, so in clinic, you do have to know the back end, the generic name for your trade name for your patient, because they're not going to know it. But we have to test you on the generic name, on the name that got approved by the FDA, not the brand name that the pharmaceutical companies show on the commercials on the TV. Okay, so when someone is toxic, they have too much digoxin. You have to reverse it with which medication? Digoxin, immune fab. And how do you know they're toxic? How do you know your patient is dig toxic? Well, A, they're taking digoxin. It's on the medication administration record. But what else? They got low blood pressure, maybe, and even then, not really, because it lowers heart rate. And yes, lower heart rate is lower heart rate times stroke volume, low cardiac output, but it also increases contractility. So it's almost like it's a catch-22, right? When we go back to that previous slide with A, B, C, D medications, all of them lower blood pressure, and all of them lower heart rate, but only one little asterisk, so I can't say all, one little asterisk, digoxin actually raises blood pressure a little bit because it actually increases contractility. Okay, but you're going to get vagus nerve activity, and what does the vagus nerve do? Makes you throw up. So you get nausea, vomiting, diarrhea. Like, well, that's every medication. I thought that was the right answer for every medication. Well, this is like exorcist, or what's the word? Poltergeist. All right, anyways, exorcist. Yeah, right. Yeah. So I know my movies. So they're like vomiting all over the place, right? You go in the room, it's like, what is all this? It's like, oh, I took too much of my cardiac medication. Well, ding, ding, ding. That is probably digoxin, right? So that's a prominent side effect is this nausea, vomiting, diarrhea. The only reason I'll put nausea, vomiting, diarrhea on a medication for a slide is because it causes profound nausea, vomiting, diarrhea. Otherwise, that's the right answer for every medication. Okay, and it also causes yellow halos. You notice the yellow halo around the slide there. So the yellow halos are also a unique side effect. You can't really explain it that well. Why does it cause yellow halos, not red halos? You can't really explain it. So that's one of those things. Just like you have to be, you have to be cool at parties and win at Jeopardy when you say yellow halos for digoxin, right? It's also what Van Gogh had. That's why all of his paintings have a yellow halo on them. Okay, he had dig toxicity. Digoxin is also found in a plant, right? And that plant's like the foxglove plant, and he ate it to calm his nerves, to lower his heart rate, right? He had some psych issues, right? He bit his ear, tore off his ear. He wasn't Mike Tyson, was he? Anyways, he went deaf for some reason, and then he also saw yellow halos and painted them. Okay, so why would you get dig toxic? Well, you have this mechanism right here. If we increase calcium, they're going to have more calcium available. All the calcium is going to go in, and that will potentiate this whole digoxin mechanism, and that makes us higher risk for dig toxicity. Low potassium and low mag. Well, low mag means low potassium, but low potassium will also trigger this mechanism, right? Dig binds to available potassium sites, and if I have more potassium sites available, I have more dig available to do its thing. Okay. Renal failure. If you know your renal failure, you know that patients with renal failure have high potassiums. But the reason why renal failure causes dig toxicity is because less dig is getting peed out by the kidneys, right? And then other anti-arrhythmics can potentiate it. There's also the ST segment might be scooped. There's just other fun things. But the big thing is that it's lowering heart rate, and it's causing nausea, vomiting, diarrhea, and causing yellow halos, which are showing someone has dig toxicity. And also, if you look at the dig level, it is high, right? It used to be that the NCLEX would test you and you have to know all the levels of all electrolytes and medication levels and everything. But now it'll tell you the normal range right there, right? Yes?
What do you mean by yellow halos?
Yellow halos is when you see, what you see is yellow or around your vision. Okay?